we'll be discussing about your topic, the constrictive, restrictive and pericardial diseases.
That's right, yeah.
So sir, can I ask you how commonly do you see this kind of patients in your clinical practice in the country?
See, on an average, you may find about 5 to 6 cases every month.
Okay.
6 cases every month. It's not an uncommon clinical problem, but unless you keep it in your mind, it will never strike you that you are dealing with a pericardial disease. You may go astray in your diagnosis. So it's very important to keep in mind this very important clinical diagnosis.
Right, sir. And sir, if you compare the epidemiological presentation, do you see the numbers are similar like our India and this eastern part of the world versus the western part of the world?
See, in India itself, you may find tuberculous disease of the pericardium is far more common in probably in Orissa, Rajasthan, Uttar Pradesh, Madhya Pradesh and other places. But in Kerala, it has become rather rare. But post-operative pericardial diseases and post-cancer treatment pericardial disease, post-radiation pericardial diseases have become fairly common. At the same time, dyscollagenosis is a common problem everywhere.
Right.
And dyscollagenosis could be associated with pericardial disease also, where diagnosis and management of pericardial involvement is very important.
Right, sir. So, is there any regional variation in our country, sir? Do you see?
Except in tuberculosis, there's not much of regional variation. Tuberculosis become rather rarer in Kerala as well as in Karnataka, comparatively rarer.
Right, sir. So, sir, you said around 5 to 6 patients in a month
Exactly,
you see in your practice. So, typically, these patients present with what kind of signs and symptoms?
See, the classical presentation of acute pericarditis is pain in the shoulder, epigastrium, and or the precordium.
Right.
But that is not the sine qua non of diagnosis of pericardial disease. But it should strike you that in such patients you have to carefully examine, look for the pericardial rub, do an echo, look for the pericardial effusion or long-term pericardial disease like constrictive pericarditis. Many long-term diseases may not have any specific symptom in relation to pericardium.
Right, sir. As you rightly said, the clinical signs and symptoms are not
Exactly.
much relevant for diagnosing
That's right,
pericarditis,
exactly.
apart from might be the pericardial rub.
That's right,
So, what are the typical diagnostic or imaging modalities you look for, sir?
See, most important imaging modality is definitely echocardiogram. Even in the ER, the moment you think that there is some pericardial disease, you have to order an echocardiogram in the ER itself, or on the way to the admission, on the way to the ward, an echocardiogram should be done. Because diagnosing pericardial effusion and identifying if there is an evidence of tamponade is so crucial for the patient's prognosis. Because tapping it as early as possible will relieve the patient of all the symptoms and will give you an opportunity to make a very specific diagnosis from the fluid which you have removed.
Right.
So it's a very important way of looking at it.
So, do you see, sir, it's a challenge in diagnosing pericarditis in normal setup of hospitals, or it has to be diagnosed in tertiary care of hospitals?
See, it should be diagnosed in ordinary hospitals, but many of those patients may have to be referred to tertiary care centers for detailed workup and management.
Right. Like, sir, constrictive versus restrictive, how do you typically differentiate between these two types?
In the broad sense, there is nothing common between them.
Right.
They are radically different because the restrictive cardiomyopathy has its own group of problems like infiltrated diseases, endomyocardial fibrosis, and the dyscollagenosis. These things are all producing different presentations. But idiopathic restrictive cardiomyopathy may present with biatrial enlargement like constrictive pericarditis. And you find it may be very difficult. Rarely, I have seen at least 2 cases where diagnosis was extremely difficult. It went up to the phase of an attempted pericardiectomy.
Right.
Many a time, if you do a detailed echo, you will identify there is a myocardial involvement in restrictive cardiomyopathy, and you will find myocardium is normal in constrictive pericarditis. The echo Doppler signs will differentiate the normal myocardium from the abnormal myocardium or restrictive cardiomyopathy.
Right,
And
sir.
peculiarly enough, you will find that in constrictive pericarditis, with the diastolic pressure is going up, the E by E prime comes down. Unlike in every other disease, when the diastolic ventricular pressure goes up, E by E prime also goes up. The paradoxical endless paradoxes is something which is very peculiar and should be looked into, like the S waves in the tissue Doppler between restrictive cardiomyopathy and constrictive pericarditis. S will be very small in restrictive cardiomyopathy. It will be absolutely normal in constrictive pericarditis.
Right, sir. And sir, how do you see the tamponade patients, pericardial tamponade? Is it very common in your practice or?
Not uncommon.
Yeah.
Probably every month, two or three patients do come with tamponade,
Right.
and this has to be diagnosed. It's an absolute cardiac emergency. Should suspect in the ear,
Right.
and immediately on a fast track admission come to the ICU or to the cath lab for tapping the pericardial effusion. Diagnosis could be immediately made by a detailed echocardiography where high intrapericardial pressure compressing various chambers. Initially the atria, the ventricles will be easily made out, as well as the fixed chamber in which the ventricular interdependence is demonstrable by tricuspid flow and the mitral flow. Tricuspid flow increasing on inspiration more than 25%, mitral flow increasing on expiration by more than 25%, as well as the pulsus paradoxus being demonstrable by echo Doppler. Doppler will definitely show it.
Right. So, sir, for tamponade, definitely there is a definitive etiology. So, management-wise, is it very easy to manage tamponade rather than constrictive or restrictive
See,
pericarditis?
only after tapping you will know what's going to be the natural history when you look at the fluids.
Right.
For example, we had one lady, 45-year-old lady, who came with acute tamponade. We aspirated, but on detailed history, and by the time we got detailed history, patient had small joint involvement. I immediately called up the rheumatologist and wondered what to do. He said, start on methotrexate, start on heavy dose of steroids. The first dose of steroids was given intravenously, and within 48 hours, the recovery was remarkable. By the third day, there was hardly any effusion, but the pericardial edema was still present on echocardiography. So management depends upon the accurate diagnosis, clinical as well as by fluid examination.
Absolutely, sir. And what about the managing constrictive or restrictive pericarditis patients, sir?
Once you diagnose constrictive pericarditis, you have to give antituberculous treatment if there is a suspicion of its tuberculosis.
Right.
If it's postoperative, you have to treat it accordingly, but pericardial removal is the only method by which pericardial stripping by the surgeon will remove the constriction and allow the ventricles to pump normally and the atria to function normally.
Right, sir. And how is the prognosis of these patients?
See, if you diagnose it in time, the fibrous tissue may not have infiltrated into the myocardium. In such a scenario, they have a very good prognosis. In late stages, when the fibrose involves the myocardium infiltrating into the myocardium, you may find that the ultimate results may not be that good because there is a myocardial involvement in addition to the pericardial disease.
Right, sir. Fantastic. So, sir, may I ask you just to summarize in 2-3 key messages for the audience?
Clinicians should remember that there is a disease called pericardial disease. That should, whenever they examine a patient, it should strike them, is this a pericardial disease or not? Unless it strikes them, they will never diagnose.
Right.
2, decide on what kind of imaging, especially echo, to be done very early, immediately, or not. Do it immediately. And number 3, specific diagnosis is very important for managing the disease.
Our India and this eastern part of the world versus the western part of the world?
See, in India itself, you may find tuberculous disease of the pericardium